So last week we were talking about your adrenergic drugs, your alpha agonists, your alpha blockers, your beta blockers, and your ACE inhibitors, your renin angiotensin drugs, your ACE inhibitors, your ARBs, and your aliskiren. So now we're going into calcium channel blockers. So this is the other big group of drugs that are used to treat hypertension. Calcium channel blockers will impact the way that the calcium channels in your muscles function, so these are also good for arrhythmia. In early stages of heart failure, it's not a challenge with the newer ones, the dipines, but as heart failure progresses, calcium channel blockers are actually contraindicated because it's going to slow down the pump of the pressure of the pump. And in heart failure, that's the issue. The heart's not pumping strong enough. These drugs are also effective in treating angina because it does lower the workload on the heart, so it doesn't require as much oxygen. So whenever the heart or any muscle can work without less or work with less oxygen, it's not going to be strained as much. Side effects: anytime we lower blood pressure, it can lower it too much. We end up with hypotension. Flushing and headache can occur. It causes vasodilation. That gives that flushing. Those blood vessels open up, blood flows to the surface. Bradycardia slows down your heart rate, and it can slow other things down and cause constipation. And we just use CCB. So there's two different groups. You don't have to break them down into the dihydropyridines and the non-dihydropyridines. But these dihydropyridines we have amlodipine, which is Norvasc. It comes in tablets, 2.5, 5, and 10 milligrams. Think of normal vascular kind of thing. You know, we're making those blood vessels dilate so that we get that blood pressure to come down. And these specifically end in dipine. So there's two generations of calcium channel blockers. The older ones, they have their own stems that don't match anything, but the newer ones end in dipine. And these are the ones that early stages of heart failure are okay. The other one is nifedipine, which is Procardia. And it comes in two brand names. Procardia is an extended release formulation. It comes 10, 30, 60, and 90. The 10 is kind of a regular release, but when we get into those higher doses, it can be irritating to the stomach. So you see on the labels, it has the GITS, the GITS at the end. That's a gastrointestinal therapy system. So it has a coating on it so that it won't irritate the stomach in those 30, 60, and 90 milligram tablets. So that's what that GITS means. It has to do with the dissolving. And that's the extended length formulations. So Procardia XL. The regular release is just Procardia. Adalat CC is also an extended release. It comes as a tablet. It comes in 30, 60, and 90. I couldn't find a 90 label. So you see the 30 and 60s look similar. It's just color changes on the label. And again, you got dipine as a drug stem. Now, these are the non-dihydropyridines, and like I said, it really doesn't have a drug stem. Diltiazem is one of the older CCBs. It's known as Cardizem. There's actually a bunch of different brand names. Cardia is another one. Cardizem comes in different release formulations. These are not interchangeable. So we have regular strength Cardizem, 30, 60, 90, and 120. Then we have Cardizem CD, which is a capsule, and that's 120, 180, 240, and 300. And then Cardizem long-acting is a tablet, and that comes in multiple strengths, 120, 180, 240, 300, 360, 420. So lots of different strengths for the patient's needs. The regular release Cardizem can be cut. So we see that those tablets are scored, so if they need to cut that dose, they can. Or to ease the patient's cost, maybe they need 30 milligrams twice a day. Instead of dispensing 30 milligram tablets, we could give a 60, cut it in half. On the tablet count, if we did count for count of tablets, they may be similar in price. The 60 may be a little bit more expensive, but if you were to cut it in half, it may turn out cheaper than having a 30 full. Verapamil is the other older calcium channel blocker. Kalen is one of the brand names, and Kalen comes regular release and SR, sustained release. They are all tablets, and even the SRs can be cut in half. So it's how the tablet itself is formulated. A lot of times your SRs and your LAs and your XLs and all those, you can't cut them in half. But some of them you can because of how the tablet is actually formulated. So regular strength Kalen comes 80 and 120. And Kalen SR comes 120, 180, and 240. And then Verelan is another brand name, and it's misspelled on your drug list. I have it V-E-R-A-L-A-N. It's E-L-A-N. And those are capsules. We've got Verelan PM, 100 milligrams, but Verelan capsules 180. I got them out of order. It should be 120, 180, 240, and 360. I got confused and reversed those this morning. I have no idea what this little thing is that always shows up when I open up PowerPoint. So Verelan is capsules and Kalen is tablets. So those are your antihypertensive agents. Now, we also use diuretics. And diuretics do what? They increase urine production, which increases fluid output. Now, what draws the water into the urine is the body not reabsorbing salt. Because wherever salt goes, there goes water. So if your body doesn't reabsorb the salt goes out, the water goes out with it. If your body reabsorbs the salt, your body's going to reabsorb the water. We would have fluid retention. Diuretics work in different ways. We're not going to go into a lot of details. Most of them work in the nephron, where urine is being formulated. So loop diuretics will work in the loop of Henle. Osmotic diuretics are used specifically in controlling brain swelling. So we don't use those to lower blood pressure. Now, the diuretics that we use in treating hypertension include those loop diuretics. They're going to be the most potent of the group. They're going to pull the most water the quickest. Then we have the thiazides. The thiazides are the most prescribed. They work almost as well as the loops, but not quite as, they're not going to pull as fast. And then we have potassium sparing. So what happens with your loop and your thiazide is it's just putting out salt. It doesn't care if it's sodium chloride or potassium chloride. Now, your potassium sparing is only going to put out the sodium chloride. It's going to keep the potassium in your body. And I'll talk more about that in just a minute. So your loop diuretic, the one on your list, is Lasix. Furosemide is the generic name. Lasix. There's a couple of things about Lasix. The name. Think of the last dose at 6. Why do you think patients don't want to take these tablets or medicine any later than 6 p.m.? They'd have to go to the bathroom. They'd be up all night. So generally we say don't take, the last dose should be at 6. So Lasix is very common. It comes 20, 40, and 80 milligrams. I was like, I do have a 40 milligram tablet. I got my release a little weird. So patients can take this orally, but in the hospital, if we need to get that fluid off quick, we can give it as an injection. So it doesn't come by brand name as an injection. It's furosemide. that comes in the vial. We do have Lasix in the ampules. The other formulation is in an oral solution. Hydrochlorothiazide is a thiazide diuretic. It's most commonly known by the abbreviation HCTZ. You need to know that abbreviation. It'll show up a lot. The brand name is Microzide. It's a micronized formulation, so it's little tiny, tiny, tiny ground up. And it only comes 12.5. Now, hydrochlorothiazide will come multiple strengths. It'll come 25 milligrams. It even comes as an injection. So, thiazide diuretics end in thiazide. Your loop diuretics, furosemide, bumetanide, torocimide. There's a lot of other things that end in mide, so it doesn't really work to remember mide is the drug stem. Now, these drugs, like I said, they're going to pull salt. They're indiscriminate. They're going to pull sodium. They're going to pull potassium. If we lose too much potassium, what's that called? Hypokalemia. Okay? Now, if you don't have enough potassium in your bloodstream, your muscles aren't going to function right. That includes your heart. So if your potassium levels drop too much, you can have arrhythmia, and that can be very serious. So patients who are taking these types of diuretics are often told, eat foods that are rich in potassium, or they're told to take a potassium supplement so that they don't lose out on that potassium. Now, the other type of diuretic is a potassium-sparing diuretic. So it's going to put out the sodium, but it's going to keep the potassium. Now, this drug is called spironolactone. Students always have a hard time with this one. Spironolactone. Just like it's spelled. It cracks me. I'll have a student, it's happened to me more than once when I went on a site visit where they were trying to tell me something about spironolactone, and they're like, I'm like, yeah, spironolactone, aldactone. I couldn't find a label for the 100 milligrams. It comes 25, 50, and 100 milligrams. Now, it's putting out fluid, so everything in our body is concentration-based. How much of a concentrate, how much of a component is in the fluid? If we're pulling out the fluid, but we're leaving the potassium behind, what happens to the concentration, in theory, of that potassium? Does it go up or down? It goes up because there's less fluid, right? So what is that condition called? Hyperkalemia. Yay! You make me happy. So that's a concern. Now, sometimes we'll mix these together. We'll put hydrochlorothiazide with a potassium sparing because you have one that's going to put potassium out. You have another that's going to keep potassium. They cancel each other out. So that's where we get the combination. Triamterene is another potassium-sparing diuretic. And it's mostly, it can be by itself, but it's mostly used in combination. And this is a combination of potassium-sparing with hydrochlorothiazide. Comes in two names. The capsule is diazide. Diazide only comes in one strength. It comes 25 milligrams of the HCTZ with 375 milligrams of the triamterene. Now, Maxide is a tablet. It comes 37.5 milligrams of triamterene with 25 milligrams of hydrochlorothiazide, or double that. So Maxide 25 is kind of the half strength, where Maxide is the full strength, 75 milligrams of triamterene with hydrochlorothiazide 50 milligrams. So it's kind of confusing in a way, but it's not. It's weird. Diazide puts the hydrochlorothiazide first. Maxide puts the triamterene first. But if somebody just puts down triamterene with hydrochlorothiazide, they would have to tell us, do you want tablet or capsule? But if they say diazide, it's capsule only. If they say Maxide, it's tablet only. And the Maxide has a very unique shape to it. It's kind of like a little bow tie. So I was saying, if somebody's taking a loop diuretic or a thiazide diuretic and they have the potential for hypokalemia, bless you, then we would use a potassium supplement. So potassium is known as potassium chloride. It's not the only way that we have potassium. It also comes potassium phosphate, but that's mostly injectable. The most common oral formulation is known by the brand name of Chlorcon. There's a couple different variations of this. Cader, there's a few different ones. Chlorcon comes in a powder for oral solution, so we would reconstitute it. It comes in sprinkle capsules that we would open and sprinkle out, and it comes in 8 MEQ and 10 MEQ, Chlorcon 8 and Chlorcon 10. Electrolytes are usually measured in milliequivalents, MEQs. These have the milligram equivalent on there, but rarely do we use milligrams when we're ordering the electrolytes. It's usually MEQ. Don't get freaked out. MEQ is just a unit. Yes, ma'am. Thiazide? There's two spellings. Right there you go. It was probably just a typo. There we go. So you also notice that these have like a little coating on them. Sometimes they come in capsules. They come in it depends on what the brand name is or if it's a generic product. It comes in an oral cup that we use in the hospital. Usually, again, it's going to be generic in the hospital most often. Another combination antihypertensive agent is beta blockers with a thiazide diuretic. Bisoprolol with hydrochlorothiazide is Zyac. It comes 2.5 of the beta with 6.25 of the thiazide. So the hydrochlorothiazide stays the same between all the tablets. It's 6.25 milligrams. The bisoprolol changes. We've got 2.5, 5, and 10 milligrams Zyac. Benazepril, an ACE inhibitor with a hydrochlorothiazide, is low tensin HCT. Well, benazepril is low tensin. Add hydrochlorothiazide, and they added the HCT. Don't know why they left off the Z. Maybe because, I don't know, I don't think anybody owns HCTZ. It's just an abbreviation. The HCT kind of left me unsettled when this drug came out because we also use that abbreviation for hydrocortisone. So it was like one of those weird things. But low tension, lower tension, lower pressure, and hydrochlorothiazide. It comes 10 and 20 with 12.5 milligrams of hydrochlorothiazide and 20 milligrams of the benazepril with 25 milligrams of the hydrochlorothiazide. And as we see, it's tablets, and they are scored. Another ACE inhibitor with a thiazide diuretic is lisinopril with hydrochlorothiazide. The brand name, one of the brand names for lisinopril is Zestril. And an old brand name for hydrochlorothiazide was Oretic, and now we have Zestoretic. So they combine names. It comes 10 per 12.5, 20 per 12.5, and then I could not find a label for the 20 to 25 version. But you see, they're very similar in the way the appearance of the label is. The only change in there is kind of that little color strip highlighting the dose strength of the tablets. And then we have ARBs with hydrochlorothiazide, irbesartan, Avalide with hydrochlorothiazide. Avalide comes 150 of irbesartan or 300 of irbesartan with 12.5 of the hydrochlorothiazide. Again, All of a sudden, it's leaving my head. Irbesartan. Avapro is irbesartan, right? Avapro. I believe that also had a little heart on the tablet for Avapro. And then losartan with hydrochlorothiazide. Losartan is Cozar, and we add hydrochlorothiazide, we get Hyzar. So hydrochlorothiazide plus the Cozar, Hyzar. And that comes 50 and 100 with 12.5 of the hydrochlorothiazide and 100 of losartan with 25 milligrams of HCTZ. Avalide? Avalide is the brand name for the combination of irbesartan with hydrochlorothiazide. So Avapro was just the irbesartan by itself. So a lot of times they'll take part of the original name and change it up. Not always, but sometimes. And then valsartan, which by itself is known as Diovan, but when we add the hydrochlorothiazide, they add that HCT again. So Diovan HCT comes in multiple strengths. We've got 160 with 12.5 or 25 milligrams of hydrochlorothiazide, and we've got 320 with the same mix of hydrochlorothiazide, either 12.5 or 25. And these are all tablets. And we have an ARB with the neprilysin inhibitor. This is a new drug. It's only been out maybe 2 years, a little over that, maybe, not very long. This drug is specific for heart failure. This is not used for hypertension. This is only used for heart failure. And it's for the earlier stages, not congestive heart failure. This drug is Entresto. We probably see it on TV all the time, right? It comes in multiple strengths. We've got 24 milligrams of sacubitril, which is the inhibitor, and then valsartan, the ARB, 26 milligrams. Then we have 4951 and 97103. They're just weird dose strengths, right? We're so used to everything being like 1, 2, 10, 5, 25, 12.5, 6.25. That kind of makes sense. When we get things like 49, it's like, how do they decide that it's not 50, right? 50, no, 50 is too much. 49, perfect. So this drug, like I said, is used for heart failure, Entresto. Lots of combinations, right? Lots of combinations. These are combinations, calcium channel blockers with angiotensin receptor blockers, ARBs. These are used for hypertension. Amlodipine with valsartan is Exforge, and it comes multiple strengths. We've got 5 and 10 milligrams of amlodipine with 160 milligrams of the valsartan. And we have 5 milligrams with 320, and then 10 milligrams of amlodipine with 360 valsartan. Couldn't find a label. I can find the tablet, I couldn't find the label. Sometimes I can find the label, and I can always find the tablet. I have Lexmark. I might have to wait till I get to school to find it, but I can always find it. Now, amlodipine with benazepril, and here's my proof. I got all those off my database here at school, but I had a real hard time finding those Lotril labels. And they're mixes, so they're 6 different strengths, and they're from top to bottom. So Lotril is a combination of amlodipine, Lotensin, with benazepril. Benazepril is a Lotensin. Amlodipine is Norvasc. My brain, it's like, wait a minute, you're making me go backwards. So the Lotril comes from the Lotensin. I don't know how the amlodipine kind of fits in that one, but it does. All right, so those are all antihypertensive. So what kind of questions do you have? Now remember, cardiovascular disease is one of the most common conditions, high blood pressure. It's like one of the #1 treated conditions, so we will be dispensing a lot of these drugs. I haven't gotten there yet. All right. Now let's talk about arrhythmia. So some of the drugs I've already talked about can be used to treat arrhythmia. Calcium channel blockers, beta blockers. These are drugs that are only primarily used in arrhythmia. So when somebody comes into the hospital or they see their doctor and their heart is out of rhythm, we need it to get back in rhythm. So there's a couple different conditions that can happen. If the heart's not beating properly, then blood is not moving through the body properly. And it kind of depends on what part of the heart is out of rhythm. Because we have that whole conduction system, if you remember from 109. So the signal starts at the SA node, and it goes through the AV node, down through the bundle of His to the Purkinje fibers, and it's sending an impulse. And the way your heart beats, the top beats and squeezes and pushes the blood through the valves down to the bottom chambers, to the ventricles, and then the bottom compresses and pushes it back out to the rest of the body. So it's supposed to work in this rhythm, in this sequence of impulses. Well, if something gets off beat, it's not going to get the blood where it needs to go. So if the top part, the atrium, is not beating in the right rhythm, out of sync, it's called atrial fibrillation. And the top doesn't fill up enough to send the blood to the bottom. But what can also happen is it can cause some blood to stagnate. So a very common concern with somebody who has atrial fibrillation is blood clots. So some of the blood thinners that we talk about are used specifically in patients who have AFib, or atrial fibrillation, which is also abbreviated AF. We want to get the heart back in rhythm. Now, if the bottom isn't beating properly, especially if it's squeezing too soon, like the top hasn't finished filling up the bottom and the bottom starts to squeeze out, well, you're not going to have enough. That's called a PVC, which stands for premature ventricular contraction. People can die because one of the things that's getting pumped out to the body is the blood supply to the heart. So if not enough blood is getting pumped to the heart's not going to respond properly, you can have a heart attack. So PVCs are very, very serious. So we want to control that arrhythmia. We need to get that heart back in rhythm. One of the antiarrhythmic drugs is known as amiodarone, and the oral formulation is known as Pacerone. Comes 1, 2, and 400 milligram tablets. Now, Nexterone is a premixed IV. We would use that in the hospital for somebody who's has arrhythmia to try to get it back into rhythm. And then we eventually switch them into some kind of oral antiarrhythmic. Now, diltiazem and cardizem, those calcium channel blockers, are also used for arrhythmia. And they come in injectable forms, and we can use those in the hospital to convert. When we take a patient from arrhythmia and get them back into a normal rhythm, that's called conversion or cardioconversion. We want to get them back into rhythm. This drug, digoxin, is a cardiac glycoside. That's its class. We refer to these drugs as cardiotonic. So tonic means pertaining to tone. When you want to strengthen your muscles, you tone up, right? You increase the muscle tone. So here, this drug is to increase the tone of the cardiac muscle, which is why it's known as a cardiotonic. It's a description of how this drug is working. That's why it's effective at treating heart failure. Because in heart failure, your heart's just not beating strong enough to pump. So if we increase that strength, we get a better pump. It's not going to increase the workload on the heart. That's a key component. Now, it also helps with the rhythm. This drug is digoxin, which has a brand name of lanoxin. They match up pretty nice. This is a very old drug. It's a synthetic version of a natural substance called digitalis that comes from a plant, the foxglove, which is actually a poison, but it works. We don't use digitalis anymore. This drug has a very narrow therapeutic index. Patients have to be careful. They can get digitoxicity. So if they're dehydrated, it can change the way this appears in concentration in their bloodstream. There's an antidote for this drug. I'll talk about that in a second. So digoxin comes in tablet form, 62.5 micrograms, 125 micrograms, or 187.5 micrograms. Comes as a pediatric elixir. We have a lot of babies that have cardiac problems with arrhythmia, things like that, and then it comes injectable. So we could give this as an IV as well. The antidote, if somebody's got digitoxicity, the drug is called Digibind. It binds up the digoxin. Its generic name is digoxin immune fab. But we do have an antidote because this does have a narrow therapeutic index. So those are your additional antiarrhythmics outside of the ones, some beta blockers, some CCBs that we use for arrhythmia. Questions about arrhythmia? The next group of drugs are nitrates. Nitrates are vasodilators. They open up blood vessels. They let the blood flow. When the blood flows, more oxygen gets where it needs to go, and we don't need to work harder to get it. It's like your hose at home. If you're not blocking it, if you're blocking the stream, you get high pressure. If you take your thumb away, and it just flows. So nitrates are just to open the blood flow. Side effects, it's vasodilating. It causes flushing. That flushing, that extra push of that blood flowing can cause a headache. Because it's vasodilating, it causes pressure to go down, so hypotension can be a concern. And then it can also make a patient feel a little bit nauseous. Primarily, we use nitrates for angina. Now, in an emergency situation, we give it IV for a hypertensive crisis. Other than that, we don't really use nitrates for high blood pressure. Only in the emergency situation. Now, patients who are taking nitrates should not drink alcohol. Alcohol also is vasodilating. If any of you have ever had an alcoholic drink, that first little bit, all of a sudden you feel a little warm as the blood vessels are dilating and the blood's coming to the surface. Now, the other thing is the potential lethal interaction with PDE5 inhibitors. Who remembers what PDE5 inhibitors are used for? Erectile dysfunction, sildenafil, tadalafil, vardenafil. Potentially lethal. It can cause such a severe drop in blood pressure that the heart will stop. So don't give nitrates. I was watching Bob Hart's Abishola last night. Anybody else watch that show last night or ever? So she was being cranky, and she kind of went off on a doctor because the doctor's taking care of a patient. And he says, start him on nitrates. And she's like, you can't start on nitrates. He's taking vardenafil. I'm like, that goes the other way around. Stop taking the Viagra and use the nitrate. The Viagra's not going to save your life. The nitrate will. But they were correct in that it's harmful, but her story was not 100% right. That's why I hate medical shows, because I'm like always like, no, that's not how it works. Now, we use it for angina, and the most common one is nitrostat, nitroglycerin. So it comes as a tablet, nitrostat. or it comes as a spray, nitrolingual. Now, we're changing things, okay? These are revised labels. On these labels, we only see the milligram. The old label used to say 1/150th of a grain, and then have the milligrams in parentheses, or 1/300th of a grain, which I could not find a 0.2 milligram tablet anymore, so I guess they don't make them. But they have the 0.3s. I guess I can go look at my other resource. Now, nitroglycerin comes in other forms. It comes in patches. That would be transderm nitro. If somebody's using a nitroglycerin patch, they need to make sure their instructions tell them, take it off. Don't leave it on for more than 12 hours a day. So usually they put the patch on in the morning and then take it off before bed, because we don't want them sleeping with this patch on, because it can cause their blood pressure to drop and nobody would notice. If your blood pressure drops while you're awake, like, you're going to have some weird symptoms, and that would be able to identify. One of the challenges is we get people in the emergency room every day, like, with the symptoms of having a heart attack. They open their shirt to put on the leads to check their heart rhythm, and they've got nitroglycerin patches all over the place. They're supposed to take it off. Take the old patch off before the new patch, and go 12 hours without having the patch on. It also comes in an extended release capsule for people who need that control for their angina, but those aren't in the top 250, 300 drugs. So nitrostat and nitrolingual are. So these are emergency drugs. So on something that we did, one of the project problems, I know we were at, maybe it was math. The usual thing, if somebody's getting chest pain, they take one dose. They wait 5 minutes. If they're still feeling chest pain, they take a second dose. They wait another 5 minutes. They take a third dose and they call 911, because they're probably having a heart attack. It's not just lack of oxygen to the heart. So usually it says Q 5 minutes times 3 doses in how the order is written. Now these tablets, they're itty little tiny tablets. They fit under your tongue. They may or may not tingle. Doesn't tell you whether it's working or not working. The nitrolingual can be sprayed on or under the tongue. A longer range use or longer use nitrate is isosorbide mononitrate, and we got that nitra in there for the nitrate. There's an isosorbide dinitrate, but it's not as commonly used. The isosorbide mononitrate IMDR, 30, 60, 120. And when I was looking these up, Monocat is no longer sold. So that was the second drug that was on your list. So IMDR, or isosorbide mononitrate. And again, that nitro or nitra to identify it's a nitrate. So those are drugs we use for angina. Questions? Now we come to, okay, the heart we've got to take care of. But one of the other things that a lot of people have is high cholesterol. So this isn't the cardiac drugs because the cholesterol is in your bloodstream. And if we have high cholesterol, it can cause problems with our heart. We can get coronary artery disease, CAD. We can block those arteries. Now we can't get the oxygen through. We have a heart attack. So that's why these are all linked together. So the goal is to lower cholesterol. Now, who remembers the different kinds of cholesterol? Who remembers the different kinds of components to cholesterol? LDL, HDL, triglycerides, and then we have VLDL. All right, so LDL and HDL are kind of the two that we look at really to determine what is our cholesterol level. So we want to keep our cholesterol under what number? Does anybody know? Total cholesterol. Under 200, right? So total cholesterol, we want to keep it under 200. Blood. We want to keep it under 200. So we have LDL and HDL that go into this number of 200. Then over here on the side, we have these two agents. We have triglycerides I want that one red. And we have VLDL. Okay. LDL is which one? The good or the bad? The bad. I picked red. Right? Like the devil. Bad, bad. It's low down, sticky. It sticks to your vessels. It clogs them all up. HDL, therefore, is the good. We need this. It's slippery. It helps make cell membranes. It helps make your hair. It helps make your body function properly. We need cholesterol. It makes steroids in your body. It's a chemical component. Not all cholesterol is bad. Too much of anything is always bad, right? So we need the HDL. Now, our body makes that. There's a chemical reaction in our liver. Cholesterol is made in our liver. It takes the chemical precursor, it has a reaction, and the end result is cholesterol. I'm going to talk a little bit about that reaction in a few minutes. So we need to keep this down, usually above a 40 is where we're looking, and we need to keep this up, and we need to keep this one down. Now, VLDL is not necessarily bad. I know it says very low lipid density, but we need VLDL to make HDL. The challenge is when we have too much VLDL and we don't use it all to make the HDL, then the leftovers get converted to LDL. So we want to manage the VLDL level so that we have enough to make the good and not too much left over to turn to bad. Think of it in a sense, to do a comparison, a parallel kind of similar. Eating sugar is not necessarily bad. Your body needs it, carbohydrates, for energy. But when you eat too much, what happens? It turns to fat, right? Then it becomes something bad. When there's too much, it becomes something bad. Now, triglycerides are a precursor. Triglyceride, well, this is sugar related, but Glycerin. Does anybody know what glycerin is used for? Okay, we use it to moisturize. It's in soap. We actually have it in food products. If you've ever eaten professionally prepared icing, there's glycerin in that. It's a stabilizing agent. There's food grade and then there's other grade. It helps to stabilize things, but it's like soap in its field. It's slippery. Too much of that can clog things up. When patients have elevated triglyceride levels, they're at risk for having a stroke. Cholesterol not just blocks the arteries in your heart, but can block vessels in your brain as well. So stroke and a heart attack are very similar in their causes. It's just different locations. So we want to keep those triglyceride levels down. We want to raise our HDL up and lower our LDL. So those are the goals. Now, like I said, cholesterol is made in your liver. There's a whole bunch of things that it's important for. Now, one of the other things it's important for is bile. So we make bile in our liver, we store it in our gallbladder, and it breaks down carbohydrates and fats in digestion. Now, it's something that doesn't really get used up a whole lot. It's a detergent in a way that we can reuse a couple of times before it breaks down and we have to make more. So our body's only going to use a little bit of cholesterol to make that bile. So that also leads into some things that we do with how to treat high cholesterol. I'm going to explain each one as we get to that area. So the first group of drugs are the HMG-CoA reductase inhibitors. I'm sorry, there's no other abbreviations. HMG is already a big abbreviation. So this drug stops the cholesterol synthesis. It's the chemical. Again, if I'm doing a parallel, think of angiotensin 1 being converted to angiotensin 2, and you have that enzyme, ACE, angiotensin converting enzyme. If we take it away, that reaction doesn't occur. Well, in cholesterol, it's the precursor. HMG-CoA reductase is the enzyme. Cholesterol is the end product. If we inhibit that HMG-CoA reductase, cholesterol does not get made. Now, this is happening in the liver, so we're changing liver enzymes. So patients who use these drugs will have to have liver enzyme tests about every 6 months because there's various serious side effects. And muscle pain is the symptom of the side effect, and that's why I put those 3 stars by it. If a patient feels muscle pain or fatigue after taking this medication, they need to stop right away. They may have something that's called rhabdomyolysis. Rhabdomyolysis is when the body starts breaking down its own muscles, and it can be toxic. It can be harmful to they can die from it. So we don't want them taking it if they have that reaction to it. And it's because of how their specific liver enzymes work that reaction can occur. The most common, I didn't mean to put 2 S's on gas, diarrhea and gas, and again, because it can cause liver dysfunction, they have liver enzyme tests to make sure everything's working okay. This helps to reduce LDL and triglyceride levels. These drugs cannot be taken with grapefruit juice. So grapefruit juice will affect the enzymes in the liver. All citrus can. Grapefruit is the worst offender. These drugs include atorvastatin, which is Lipitor, lipids, right? Atorvastatin, Lipitor. We got a little bit of match up there. Tablets, 10, 20, 40, 80. Lovastatin is Mevacor, 20 and 40. That was one of the earlier ones. And these drugs are known as the statin or vastatin drugs. That is not a class. Some people say, oh, it's in the statin class. That's not a class. The class is HMG-CoA reductase inhibitor. Statin or vastatin is the stem that identifies the class. Yes, ma'am. Uh-huh. Citrus specifically, but I said that grapefruit has certain enzyme reactions in the liver that others don't have. So there is a whole list of grapefruit drug-food interaction drugs. When you prepare for the exam, I kind of give you some of those summary lists, kind of like the one I gave you the other day. Pravastatin is Pravachol. That one matches up nice. All of your statins are tablets. We've got 20 milligram, 40 milligram, 80 milligram. Rosuvastatin is Crestor, 5, 10, 20, and 40. And then Zocor, which is Simvastatin, 5, 10, 20, 40, and 80. They changed the shape of the tablets. They used to be like little Superman shape, but they've changed the shape. Merck Sharp Down, your drug manufacturer. MSD on a tablet. Merck Sharp Down. And again, these are your statins. Now, a group of drugs that are not on the list, but I was talking about how bile. We need cholesterol to make bile. There's a group of drugs called bile acid sequestrants. So how it works is your body usually will recycle bile. And every once in a while it'll replace some that's lost. But it never has to replace the whole bucket in a sense. If we use a bile acid sequestrant, or what they also call a bile acid resin, it's going to stick to the bile. So it can't be reabsorbed. That goes out of your body through your intestine. Now we don't have enough bile in our store, so it's going to have to take cholesterol to make more bile. And when it does that, it reduces your cholesterol levels. So that's another drug that's used to treat cholesterol. But it wasn't in the top 200. I just wanted to kind of pass that information on. The next group, these drugs, we put them in the antihyperlipidemics because they're going to help lower triglycerides. These are fibric acid derivatives, and they got fibra in the drug name. And I think of these kind of like brushes in there, cleaning out your vessels. Like whole grains, oatmeal, things like that. They help keep your vessels clean. I think of fiber. Keeps your vessels clean. So in that's where I get the little kind of car wash brush thing, helping to clean it. It's not literal. It's just my brain putting it together. So fenofibrate is Tricor, triglycerides for your heart. Cor is coronary, right? And gemfibrozole is lopid, lower lipids. And these are both tablets. We often combine Tricor with other things. We use niacin sometimes to help lower cholesterol or lower the triglycerides. And like I said, fibra is the drug stem for the fibric acid derivatives. Now there's a new group, PCSK9. I have no idea what PCSK9 stands for. It wasn't in the micromedics. It was just written as PCSK9. This is a monoclonal antibody, but it's specific to lower cholesterol. And it's alirocumab, which is Praluent, and it's given subcutaneously. They take it every 2 to 4 weeks. Now, how do we prevent cholesterol another way? Don't absorb the fat. If the fat's not there, it can't be made into cholesterol. So these drugs work specifically, the ezetimibe works in stopping absorption of the fats in the intestine. And that drug is Zetia. And then we combine it with the HMG-CoA reductase inhibitor for the brand name Vytorin. I haven't seen these commercials in a long time, but a while back they used to say, you get cholesterol from 2 places, from your Uncle Fred and your fettuccine Alfredo. Right? So part of it is genetics. The HMG-CoA reductase inhibitor the part that's part of your body, and part of it, the food you eat. Like fettuccine Alfredo with all the heavy cream and, you know, the good stuff, the cheese and all that to make the, so both of those, well, so they're hitting it two ways. They're stopping the absorption of the fat with the izicimab, and we're affecting the synthesis of cholesterol with the HMG-CoA reductase inhibitor. And that comes in 4 different strengths as tablets. We can also use good oil, good fats, omega-3 fatty acids. Omega-3 acid ethyl esters is Levasa, which was on your 103 list. This is a prescription omega-3 fatty acid. You can buy fish oils over the counter, but this is a specific brand name for a prescriptive drug. So eating good fats helps lower cholesterol. Anything that's solid at room temperature is a saturated fat, not good for you. So lard, if you have like old school people in your family that cook, like making red beans the right way, probably had lard in it. That's just animal fat. And beans. Yeah, pretty much. Yeah. Butter, bacon fat, all the stuff that tastes good, that's bad. Oils, liquid at room temperature, sunflower oil, saffron oil, grapeseed oil, olive oil. Those are the better fats for you because they're less likely to solidify. If it's solid outside your body, it can become solid inside your body. So that's, if you're thinking healthy, that's kind of a way to think about it. You should limit fats. Fats are important to our diet. We need fats. We cannot live without fats. Again, we need that cholesterol to be able to build those cell membranes, to have healthy skin and hair. If we don't have enough fat, your body's going to try to find it where it can, and eventually it's going to run out of resources. You're going to starve. You can die from starvation. We need some fat. It helps us feel full. But when we're thinking about our diet and how to have a balanced diet, your protein is roughly 4 kilocalories per gram. Your carbohydrates are about the same. Your fat is 9 kilocalories per gram. So we only need a little bit of fat in our diet before those calories, it's more than twice a gram in calories to what proteins are. But we need it. We do need some fat. All right, questions on cholesterol? All right. The next group, I have no idea what that word was. The next group of drugs are drugs that affect blood clots. So some people have chemicals in their body that cause their blood to clot too much. They're hypocoagulators. They have certain chemicals in their body that are overactive. Some people, if you're inactive, you kind of sit, you lay. Patients who are bedridden, can't get around, have mobility issues, they're going to be more prone to blood clots. People who fly a lot, blood can kind of stagnate, and when it stagnates, it can start to clot. So there's a lot of different things. If there's injury to a blood vessel, and it's left with a rough edge, that's where blood cells can get caught and then start forming a blood clot. So people who've had stents put in, they have a foreign body in their blood vessels. It potentially could be a place where a blood clot could occur. So they coat them with anticoagulant drugs to stop that from happening. But if you've broken a leg that bursts a blood vessel, you could have fat that gets into your bloodstream, or you could have damage that now you have a scar in there, and that rough edge. Anybody ever make sugar candy at home? Rock sugar candy? No, rock sugar candy. We did it in science class in grade school. You superheat the water so that all the sugar dissolves. It's super saturated. And then you put a stick into it, or you scratch like a piece of glass against a piece of glass so it creates a little edge. So as it starts to cool, those sugar crystals start to come out of solution. It wants to attach to something. So it has to have something to attach to. And if it attaches to a scratched piece in the glass, it kind of looks like a geode when it finishes. Or if you put the stick in, you've probably seen them in stores. That's how they make them. Well, let's pretend that sugar is blood cells and clotting factor. It just needs the right environment to come together and make that clot. So we're going to use different drugs to affect how that occurs. Now, these drugs are REMS drugs, okay? Anticoagulants. They're going to inhibit clotting. They're going to mess with the chemistry of a blood clot being formed. I'm not going into all of the different chemicals and what's going on, but basically that's happening. Now, they're not going to break down a clot. They're going to stop the clot from getting bigger or a new clot from forming. So heparin is one of the drugs. Heparin is only by injection. Our body has heparin. Our liver makes heparin. It keeps our blood from clotting, from us to become a big blood clot. But it's in balance, right? So heparin's injectable. We've got to be careful of labels. We have to reread. It comes in multiple strengths. It comes 10 units per milliliter, 100 units per milliliter, 1,000 units per milliliter, 5,000 units per milliliter, 10,000 units per milliliter. If you pull the wrong one and you give the wrong dose, somebody could start bleeding on any open wound. Back, it's been a while now, 10 years, 50, maybe longer than that. Dennis Quaid, the actor, he had twin babies. They were in NICU. The pharmacy in Mount Sinai Hospital in California, the pharmacy restocked the Pyxis machine with the wrong strength of heparin. They put in 100 units per milliliter instead of the 10 unit per milliliter. The generic manufacturer, all of their labels were blue. They were just different tones. The nurse just pulled it out and gave it to like 8 different babies. And I think 3 died. So Dennis Quaid is an advocate for technician education. That's a good thing. They wanted to blame the tech who stocked the cabinet. My thing was, that was a system failure. Yes, the tech, well, the pharmacist at the time should have checked, or whoever was responsible to check before it left the pharmacy, a second set of eyes. This is a high-risk drug. Not only is it an REMS drug, but a high-risk drug. So you're always supposed to have double verifications on those drugs. Because if the dose is wrong, it can kill, just like insulin. Okay, so the tech, maybe the tech who pulled it in the pharmacy wasn't the same tech who put it in the machine. Because usually it's not. You have somebody running the carousel, you have somebody doing the delivery. So did they verify when they put it in the drawer? And the nurse, yeah, they need to be looking at those, especially with a high-risk drug. But they just kept trying to roll it to the tech. I don't know what the outcome was, but people have died from getting the wrong strength of heparin. Heparin can be given as an IV as well. And then we're going to have to do blood testing to see, is the blood clotting? What's it clotting? Do we speed up the heparin? Do we slow down the heparin? Are they clotting too much? We speed it up. Are they not clotting enough? We slow it down. Eventually, once we get their coagulation under control, we switch them to an oral formulation of a drug. Now, another is enoxaparin, which is Lovenox. Nice little matchup with the drug names. This drug is administered subcutaneously. Heparin can be given subcutaneously. Heparin can be used to clear a line, flush a line for an IV line. Now, the thing about enoxaparin, it is a low molecular weight heparin, or an LMWH. Regular heparin is what we call standardized or fractionated. LMWs are used specifically to help prevent DVTs, deep vein thrombosis. blood clots in big vessels. Somebody's had hip surgery, something like that. A big blood vessel, a vein, it's traveling to your heart. It can get through the valves of the heart, but if it gets into a small vessel, it can block it and you can have a heart attack and die. Other anticoagulants, we have oral anticoagulants. Warfarin. Warfarin is rat poison, basically. When they give it to rats and they bleed out. But it's controlled dosing. So we saw that warfarin dose, that it's all that variable dosing kind of thing on the math problem. So it comes in many multiple strengths. It also comes in injectable form, but that's not in the top 300s. Coumadin is the most common brand name. Wisconsin Animal Farm is where they came up with this component. That's where warfarin's name comes from. Drug name. Interesting reason why some things are called what they are. A newer one, so for a very, very, very long time, up until less than 10 years ago probably, or just about 10 years ago, warfarin was the only oral anticoagulant. Now we have dabigatran, which is Pradaxa. This is in capsules. And we have apixaban, which is Eliquis, and rivaroxaban, which is Xarelto. So these are all anticoagulants. They're going to stop clots from happening. These all require med guides. These are all REMS. Now we have antiplatelets. So a component of a blood clot, think of your platelets as kind of a first responder, right? Because they're already in your bloodstream. So you cut yourself. You get some plasma in that area, and you get platelets and red blood cells that get caught up and start forming the mesh. Then the other parts, the chemicals, the thrombin and things, the coagulant part comes in and creates a blood clot. Well, on the outside, that's a scab, but on the inside, it's a blood clot. So what we see on the outside can also happen on the inside. These drugs, for the platelets, for a clot to form, platelets have to come together and stick together. Antiplatelets work by making the platelets less sticky. They don't want to stick together. So there's nothing for those coagulant components to adhere to as much. So aspirin is an antiplatelet drug by itself, which is why we tell people don't take aspirin before you go to the dentist. It can thin your blood if you take it too much. It's also why they take it low-dose aspirin to help prevent heart attacks. This drug is a combination of two antiplatelets. We have aspirin and dipyramidol, and this drug is called Agrinox. It only comes one strength capsule. Other antiplatelets include clopidogrel, which is Plavix. Now, a lot of times when we switch a patient from heparin or other injectable antiplatelet drugs, they go on Plavix. But now we have a new one called Prasugrel, which is Effient, and these are both tablets. But these are antiplatelets, so they're going to help prevent blood clots from forming. And when we talk about anticoagulants, if we give too much and people are bleeding, we can reverse their effects for some of them. This is not on your drug list, but these are kind of important things to know, because rescue agents are one of the things for the state or for the certification. Protamine sulfate is used as an antidote for heparin. It doesn't have a brand name. It's just an old drug. And adaruximab, which is a monoclonal antibody, is Prexbind. It's an antidote for Pradaxa. It binds up, just like Digibind binds up digoxin, Prexbind binds up Pradaxa. And that was one of the things that they would say, you know, warfarin has an antidote. So one of warfarin's, you don't want to switch to this other drug because there's no antidote. Well, they came up with one for Pradaxa. Now, the antidote to warfarin overdose is vitamin K. No, it's not potassium. It's a vitamin. Potassium is a mineral. So vitamin K is a fat-soluble vitamin. Phytonadione is the name for vitamin K. Oral, it's known as Mephitin. Injectable, Aquamephitin was an old brand name, but I put it there kind of to drive the point home. It's in a water solution. It's an injectable. We have vitamin K injections for babies because when babies are born, they don't have a coagulation factor. We have to give them vitamin K so they can start to clot. Because usually we get it from our food sources. It's made in our digestive system and things like that. So you have to have some things in your body for it to happen. Well, they're no longer part of the mom's body, and they haven't started making their own chemicals yet. So they give the baby a shot of vitamin K. So we give this to somebody who isn't clotting enough or who's had warfarin. So this is considered to be a coagulant. And the K part comes from, I think it's Swedish word for coagulation, which is why they labeled it vitamin K. But it is a vitamin. It's a fat-soluble vitamin. A few more and we're done. The next group, thrombolytics. These break down clots. These are known as clot busters. They will dissolve a blood clot. If you go into the hospital with a stroke or a blood clot or a heart attack caused by a blood clot, they give you this. It's going to dissolve it away. I don't think it's on your list, but these are important ones to know, especially for the hospital side. They're enzymes. They break things down. So they all end in ACE. We've got redoplase, alteplase, and TKNase. I can never say the word. They're all injectable. My mom had a heart attack. They gave her this. We got her to the hospital really, really quickly. She had virtually no muscle damage from the heart attack because she got this on board so quickly, like within 20 minutes of the onset of the heart attack. So we got that blood restored very, very quickly. And then drugs for cardiac emergencies. This is from 103 as well. If the patient's heart rate is too slow, we give them atropine. It's an anticholinergic. It's going to cause their heart rate to go up. And then drugs to treat anemia. Not enough oxygen. You're tired. There's different reasons. Main kind is you have iron deficiency. Okay? Hemoglobin in your body needs, in your blood cell needs iron to work. Hemoglobin carries the oxygen. There's different kinds of anemia. Other anemia, types of anemia, folic acid deficient anemia, you have to treat it with folic acid, vitamin B9. Pernicious anemia, it's a deficiency of vitamin B12, cyanocobalamin. The only way to treat it is with cyanocobalamin. Iron deficient anemia, the only way to treat it is with iron. So ferrous sulfate is slow Fe. Fe is the elemental symbol for iron. Iron is known as ferrous. It's sold over the counter. And then for prescription, we have ferrin sol, which is ferrous in a solution. And then to end today, my Ferris wheel. No, not necessarily. It's usually diet. You don't get enough iron in your diet. So people who are don't eat a lot of meat, red meat, could be at a higher risk for anemia. But certain foods like spinach are very high in iron. Raisins are very high in iron. Now, people who are taking anticoagulant drugs have to be careful because green leafy vegetables like spinach and kale can increase your clotting, so it can counteract the warfarin. So they have to modify their diet. Pradaxa, they don't have to. All right, questions?